Hi guys, this is the second part of the video. In this video we are going to cover about tumors of the middle ear cavity and acoustic neuroma. So first let's begin with the classification of the tumors of the middle ear and mastoid. So talking about it into a brief introduction, the tumors of middle ear and mastoid can be divided into benign tumors and malignant tumors, but despite that we have still divided into the origin part, that is primary tumor and secondary tumor, in which there is a subclassification, is benign and malignant tumors. So let's see the classification. Tumors of middle ear plus mastoid: primary, secondary. In primary we have benign and malignant. In benign we have neoplastic, non-neoplastic and differential diagnosis of glomus tumors. So in neoplastic tumors you have basically the first one, which is the congenital cholesteatoma. Then you have the second one, which is choriostoma, aberrant internal carotid artery, and high jugular bulb neoplastic tumors, which these all they come in non-neoplastics one. In neoplastic we have paraganglioma, facial nerve schwannoma, hemangioma, carcinoid, and alanoma. Then coming to the malignant tumors, over here we have carcinoma of middle ear and rhabdomyosarcoma. Then coming to from adjacent areas, you have from external ear canal, parotid gland and nasopharynx, and from carcinoma breast, bronchus, kidney, thyroid, prostate and GIT. So now let's begin by talking about the tumors of middle ear and mastoid. First one being the paraganglioma. Paraganglioma is basically a tumor which originates from the paraganglionic tissue, most common benign tumor, of paraganglionic tissue origin. Then jugulotympanic paragangliomas, basically in the dome of jugular bulb, middle ear promontory along with the tympanic branch course, which involve what Jacobson's nerve, which is a branch of the cranial nerve 9. The microscopic feature paraganglionic tissue are cell nest or ribbons, in which the type 1 and the type 2. Type 1 is the chief cells. These chief cells will produce catecholamine, and type 2 are the sustentacular cells, which actually modified Schwann cells. Then etiology and pathology. Microscopic feature paraganglionic tissue or cell nest ribbons, type 1 chief cell. This is done, right? Etiology and pathology. In middle age, 40 to 50 years, females are affected 5 times more. So benign, non-encapsulated and extremely vascular neoplasm. Growth rate is very slow and locally invasive tumor. Profuse bleeding from tumors due to abundance of thin-walled blood sinusoids. Two types are there: glomus jugularis and glomus tympanicus. Next is basically they arise from the jugular bulb dome and they invade the hypotympanum and jugular foramen, causing the neurological sign of the 9 to 12 cranial nerve involvement. They cause a compression of jugular vein and they cause the invasion of the jugular lumen. Glomus tympanicum arises from the medullary promontory, causes the oral symptoms plus facial paralysis. Spread is basically through vascular polyps in the EAC. Tumor fill the middle ear, perforate through tympanic membrane, present is the vascular polyp. They invade a labyrinth, petrous, pyramid and mastoid and invade the jugular foramen and base of skull. That is 9 to 12 cranial nerve palsies. Eustachian tube spreading causes an nasopharynx, intracranial tube, posterior plus middle cranial fossa. Metastatic spread to lung. Basically, bone is rare in 4% of cases. So whenever the tumor is intratympanic, earliest there is a hearing loss and tinnitus which is observed. The hearing loss is conductive type and slowly progressive. The tinnitus is pulsatile, swishing and synchronous with the pulse. Upon otoscopy, what we observe is a red reflex through tympanic membrane and rising sun appearance. That is when the tumor arises from the floor of the middle ear. Next is pulsation sign, positive, brown sign. Seagull speculum. This is basically when the ear canal pressure is raised. When tumor present as polyps, it presents with a hearing loss, tinnitus, history of profuse bleeding ear from spontaneous and clean. Dizziness, vertigo, facial palsy may be seen. Otorrhea is a secondary infection plus chronic suppurative otitis media with polyp. Examination reveals red vascular polyp filling the canal, which bleeds readily and profusely upon manipulation or at biopsy. Talking about cranial nerve palsy, it's a late feature after years, and 9 to 12 cranial nerve palsy may be paralyzed, which will cause dysphagia, hoarseness, and unilateral palsy of soft palate, pharynx when the involvement is more kind of 9th and 10th, vocal cord for 10th, and then what we have is this 11th nerve, which is a weakness of trapezius and sternocleidomastoid, and 12, that is half trunk atrophy, and audible bruit, that is at all stages. Auscultation with stethoscope over mastoid may reveal the systolic bruit. Then rule of 10, that is 10% familial causes and 10% is a multicentric causes. Now we'll talk about a differential diagnosis. First one is congenital cholesterate tumor. What does this mean? At first of all, it is important to know that this is what is meant by exactly whitish mass. Whitish mass, which is just behind the tympanic membrane, and it is seen mostly in the antero-superior quadrant of the tympanic membrane, but it may be also seen in the postero-superior or antero-inferior quadrant, any of the thing. And there is no history of ear discharge. Your patient won't give any history of ear discharge, and also there is no perforation or surgical procedure. So no perforation and also no any surgical procedure. Congenital cholesterate tumors develop from what? They develop from basically the epidermoid formation. What epidermoid formation they develop from, and during the development of the ear, and they are mostly seen in the male children. In male children, in the ratio of basically 3:1. Next is adenoma. What is adenoma? Adenoma is nothing but it's a vascular non-encapsulated tumor. This vascular non-encapsulated tumor is made up of basically the epithelial and neuroendocrine cells. Two type of cells it is made up of, and which is wrapped around the ossicles, and these cells get wrapped around the ossicles and finally lead to basically the bone destruction, or we can say destroy the bone. Next is schwannoma of the facial nerve. Schwannoma of facial nerve arise from the Schwann cells of the tympanic membrane. So what is important is they arise from Schwann cells of tympanic membrane. What is tympanic segment of the facial nerve? That is the seventh nerve, and they won't be visible through tympanic membrane. They may present with the following feature, like they may present with some kind of facial palsy, then conductive hearing loss is also seen, and if present to the close to ossicular chain, then some kind of giddiness it can be seen, some kind of erosion to lateral semicircular canal we can see at level of second genu. Next is hemangioma. Hemangioma of facial nerve arise from the facial nerve or its geniculate ganglion. And hemangioma are what? So they arise from the facial nerve, or we can say they arise from the geniculate ganglion, like any of it. And hemangiomas are basically how? Hemangiomas are extraneural in nature, and they cause the facial palsy by pressure. They cause recurrent facial weakness and gadolinium enhanced MRI or CT scan. What? Gadolinium. So gadolinium enhanced MRI or CT scan help in diagnosis, and they can be dissected from the nerve, maintaining the lateral continuity. Next even is the aberrant internal carotid artery. So basically what does it presents with? It presents with as a pink pulsatile mass. Very important term. It presents as a pink pulsatile mass, and this pink pulsatile mass is basically extraneural in nature, we can say, in the anterior part of the middle ear. Okay, so anterior part of middle ear, and it's sometimes incidentally found on the tympanotomy. So it can be diagnosed by HRCT, temporal bone, plus MRI angiography. Now talking about high jugular bulb. High jugular bulb present as a bluish mass of hypotympanum or mesotympanum in contact with tympanic membrane, stimulating what? Stimulates basically a glomus tumor, and this MRI can help it differentiate. MRI helps in basically the differentiation. Last one is a choriostoma in DD. It is basically how? What is? It's basically a normal tissue only, choriostoma, but it is present in a very abnormal space. And what is important more is that a normal salivary gland may present as a mass in middle ear. Okay, and it is non-neoplastic and does not grow. So basically it's non-neoplastic plus does not grow. So guys, that about the differential diagnosis, as you saw, of the paraganglioma. Now guys, let's discuss about diagnosis, that how diagnosis can be done. So in diagnosis, what is important, that a thorough history and like physical examination, both of them are very much important. That is, if a patient is checked up to find out the extent of tumor or other associated glomus tumors, serum levels of catecholamine or the breakdown products in urine वगैरह. Investigation includes CT head. What is CT head? CT head is basically using a bone window, that is 1 mm thin sections are cut, and how much 1 mm thin sections are cut. So such thin sections are cut, and it has to distinguish between two things, glomus tympanum and glomus jugulare tumor, by identification at a keratico-jugular spine which is eroded in the later. So in glomus jugulare tumor, the keratico-tympanic jugular spine is eroded, and here it's not eroded, so CT scan can help in this diagnosis. And what is important more is it is also helping us to differentiate the tumor from the aberrant carotid artery, high or dehiscent jugular bulb. Talking about MRI, MRI is a soft tissue extent tumor. Soft tissue extent tumor, it shows soft tissue extent of tumor. Magnetic resonance angiography plus venography, both of them, angio plus venography, will help to further what, it will help to delineate the invasion of jugular bulb, very important, and vein or the compression of carotid artery. Next is CT head and MRI together. Both of these together is going to provide an excellent preoperative guidance in the differential diagnosis of the petrous apex lesions. So differential diagnosis of it, both of them help a lot. Next is 4 vessel angiography. What is 4 vessel angiography? So basically it is necessary that when CT head show involvement of a jugular bulb, very important, or a carotid artery or intradural we can say extension, it helps to delineate any other glomus tumors and find the feeding vessels, and basically it permits the embolization of the tumor if required. So what does it help in? 3 things. Those are basically delineation, okay, then finding the feeding vessels, like which vessels are actually supplying the tumor, and it basically permits the embolization of a tumor if required. Okay, next is what is this? Brain perfusion in flow studies, necessary when the tumor is pressing on internal carotid artery. Basically the case needs surgery, brain perfusion, and adequacy of the contralateral internal carotid artery and circle of Willis can be assessed. If needed, xenon blood flow and isotope studies are done for precise blood flow, and the risk of stroke and need for surgical replacement of internal carotid artery. Next is what is there is a surgical replacement of ICA. Brain perfusion, embolization is basically for large tumors, important large tumors. Embolization of feeding vessels 1 to 2 days before operation is important in order to reduce the blood flow. Next we talk about is biopsy. Preoperative biopsy is very important, but for this tumor is never done. Clinical and radiological features are characteristic to make the diagnosis. A tumor is very vascular and it bleeds profusely. Thus, the likelihood of injuring the high jugular bulb or the aberrant internal carotid artery if diagnosis is mistaken. So now talking about treatment, we have surgical removal, in which we have the following approach: transcanal, hypotympanic, extended facial recess, transcondylar approach, mastoid neck approach, and we have the infratemporal fossa approach. These approaches are detailed studied in surgery, so just knowing the names now can be okay. Next, what we have, the radiation and embolization. Radiation does not cure the tumor actually, but it may reduce the vascularity of the tumor, and basically it may arrest the growth of the tumor, and this is done basically in cases of inoperative tumors, inoperable tumors, like tumors can be operated. In cases of residual tumors, in cases of recurrences, in cases of the surgery for older individuals, in cases of extensive skull base injury, older individual where the extensive skull Base surgery is not indicated. Next, talking about embolization. Embolization basically reduces again the vascularity of a tumor. Again same, but this is vascularity tumor before surgery. There's a difference between the both, and it's a sole treatment in inoperable patient who have received the radiation. So it's basically the sole treatment in inoperable patient. Inoperable patient who have received the radiation. That was about the treatment. Now we're talking short about the some tumor which is rare actually, but still it is studied, that is carcinoma of the middle ear plus mastoid. It's a malignant tumor, 1 in 20,000 cases of new patient examined. Etiology being the age group being 40 to 60 years and more common in females, and most cases being 75% in long standing ear discharge. Chronic irritation causative radium dialpenters, primary carcinoma of the mastoid air cell. Talking about pathology, may arise from middle ear being extended from the carcinoma of deep meatus. Adenocarcinoma arises from the glandular element of middle ear. Spread is through carcinoma destroy the ossicles, facial canals, internal ear, jugular bulb, mastoid, and deep bony meatus. Spread on the petrous pyramid to apex and may spread to parotid gland, temporomandibular joint, ischemic tube, nasopharynx, and infratemporal fossa. Clinical feature include chronic suppurative otitis media, blood stain, chronic foul smelling discharge, severe pain which comes at night, facial palsy, friable hemorrhagic granulations or polyps, and appearance of the vertigo, that is increase hearing loss. Diagnosis is done by biopsy and it is judged by clinical radiological examination. CT scan, angiography are used basically for the assessment. Treatment include combination of surgery plus radiotherapy. Radical mastectomy is the basically surgery of choice, and also subtotal or total petrosectomy. Then radiotherapy alone can be given as a palliative measure for tumor which involve a cranial nerves like 9 to 12 or spirituocranial cavity or nasopharynx. Yes guys, that was about tumors of middle ear and mastoid. Actually I thought that in this video acoustic neuroma also will be covered, but what happened was I didn't realize that only this topic had taken 15 minutes, and the time limit had extended. So most probably the third part of the video series will be coming, which will cover acoustic neuroma and also some kind of clinical aspects of middle ear. Thank you so much.